After you're done messing with your triple lumen, grab your guide wire and get it set so you're not fumbling around with it after you've cannulated your vein. Here's what a guide wire from a central line kit looks like. It's a wire that's within this plastic tubing fashioned in a circular manner, and that's just for convenience sake, so you don't have the wire flopping all over inside the container. When the wire is removed and fed into the vein, it becomes straight without any curve whatsoever. The end of the wire is fashioned into a fixed J-loop, and the purpose of this J-loop is to make the wire less pointy, so when it enters the vein it doesn't puncture a vein wall, or even worse if you got into the heart and punctured the right atrium or ventricle for some reason. So to properly prep, you need to arrange the wires so that J-loop doesn't give you any problems once you cannulate the vein. You take that blue conical plastic piece and slide it over the very tip of the wire, and the J-loop will disappear within that piece. It's meant for that conical piece to be inserted directly into the back of the needle once you cannulate the vein, and the wire be fed through both of those. If you don't put that tip over the end of that wire, you're going to have a lot of problems once you cannulate the vein. There are two common types of wires. The first is my favorite. It has an area where you just feed the wire with your thumb. The second, unfortunately, I think is more common. In this wire you have to advance the conical piece and advance the wire a little bit out of the plastic tubing so you have something to grab with your thumb and forefinger and be able to advance it. This also has an area where the wire is actually sticking through the back end of the plastic tubing. You need to remove that wire from that back end because it sticks in there pretty good, and you won't be able to feed the wire easily if the wire is stuck in the back end. So enough about preparation. Let's go ahead and stick the patient with some needles. We'll infiltrate some lidocaine for some local anesthetic first. We'll grab an appropriate amount of lidocaine that we talked about before, and then a couple needles that are usually in the kit. Small 25 gauge needle that's usually blue in color that will be used for numbing up the skin layer itself, and then a longer 22 gauge needle. It's about inch and a half long that we can use to infiltrate the deeper tissues if need be. After we're done putting some local anesthesia in, let's go ahead and cannulate that vein. So now let's move on to a basic technique for cannulating the vein and introducing the guide wire. Grab your syringe and your finder needle. Place the syringe on the needle. Don't place it too tight though, because you want to be able to take the syringe off really quickly and easily without moving the needle at all. Also, you want to arrange the bevel in the same orientation as the numbers on the syringe. So when the bevel is underneath the skin, you'll never have to be worried about which way the bevel is pointing. You can just look at the numbers on the syringe itself. I'll be demonstrating the initial technique here on the skin model. So take your syringe with your needle, find your landmarks, and place the needle underneath the skin. As soon as the bevel is underneath the skin, you'll have to place negative pressure on the syringe. It means pulling back on the plunger. So if you do hit a vein, blood will fill the syringe almost immediately. The angle at which you enter the skin is highly variable. It depends on the body habitus, which vein you're cannulating. But in most cases, it's about 30 to 45 degrees in respect to the skin and your needle. If you do make multiple passes to cannulate the vein, which is really common, you want to withdraw the syringe so the bevel is almost completely out from underneath the skin and reorient your needle from there. If you feel comfortable with your landmarks, you can actually use your left hand to stabilize the syringe or the bevel of the needle itself. If you do use it to find your landmarks, just don't press too hard. You can actually occlude your vein you're trying to cannulate by pressing too hard with your left hand. While maintaining negative pressure on the syringe, slowly advance the needle until the tip cannulates the vein, and you get a free flow of blood back into the syringe. Once you're satisfied that the tip of the needle is actually within the center of the vein, go ahead and grab the bevel of the needle very tightly with your left hand and stabilize your left hand. Carefully remove the syringe with your right hand and place it aside. Grab the guide wire, which should be on the sterile field right in front of you, and slowly advance the guide wire. The guide wire should be advanced to about 20 to 30 centimeters depth, And you can know this by looking at the hash marks that are very faint but on the guide wire itself, denoting every 10 centimeters. So 3 hash marks would mean that you're at a depth of 30 centimeters. If your needle is in the right spot, your guide wire should be able to be advanced with very little effort and meet pretty much no resistance. That being said, you have to put a little bit of effort into it, but if the wire is bending as you're trying to place it through the needle, you better make sure that you're in the right spot before you advance any further. So once you're certain that the guide wire is actually within the vein and within the right spot, it's time to go ahead and remove that needle from over the guide wire. It's important to always keep one hand on the guide wire as you're removing the needle. As you see here, remove the needle and then hold on to the guide wire at the skin before you take the needle off the back. You don't want the end of your guide wire flopping around. It'll touch non-sterile things, and it'll also make it harder to introduce things onto the end of the guide wire. So what I do is I curl it around into my 2 fingers so I'll have control of both the proximal skin and distal end of the guide wire itself. Next, you'll want to grab the scalpel from the kit to make your skin nick so you can introduce the dilator for the central line. Take your scalpel and make a stabbing incision through the skin right along the guide wire to open up the tract around the guide wire itself. This will make it easier to get bigger things like a dilator through the skin. There's almost always blood at the skin right where the guide wire is, so to really see where you're cutting, take some gauze and dab it in the area first before you make your incision. So after you insert your guide wire and make your stabbing incision, there are specific steps you'll have to take depending on which catheter you're placing. So first we'll discuss the steps you'll take to place a triple lumen catheter. To place a triple lumen catheter, you'll need to make a tract from the skin and the subcutaneous tissue into the vein. And to do that, you can use this dilator pictured here. For a quick recap, this is what we've done to our patients so far. We've cannulated the vein, we've put a guide wire in, taken out the needle, and then we've made the skin incision. Next step is to take the blue dilator and insert it onto the end of the guide wire and advance it down onto the skin. When initially making your tract with the dilator, you have to use a decent amount of force to get the dilator in through the skin and subcutaneous tissue down into the vein. You should probably insert the dilator into the hub to make sure that you've gotten into the vein itself. So after removing the dilator completely from the guide wire, we'll finally get to placement of the triple lumen catheter itself. Grab your already prepped triple lumen catheter and insert the tip onto the end of the guide wire. Advance the tip close to the skin, but you'll have to feed the guide wire retrograde back through the triple lumen until the distal end comes out against the brown port. So keep feeding the guide wire backward out of the body until the very end of the guide wire pokes its head through the little brown port. When the wire finally does appear out the brown port, you go ahead and grab it with the hand that's not feeding the wire back, so you always have one hand on the wire, and then you feed the catheter to its appropriate depth at the skin. When you're satisfied with the depth of the catheter, go ahead and completely remove the guide wire from the catheter. We'll discuss catheter depth and method of securing the catheter in a second, but before you do that, you have to go ahead and flush each catheter port and make sure that they're all returning blood and flushing easily. Using your flush, take a syringe and connect it to one of the triple lumen ports. Hold the syringe vertically with the plunger in the air. Withdraw back on the plunger until you see a little bit of blood in your syringe and you're satisfied that the port does return blood adequately. Flush with a couple cc's with your syringe to clear the catheter of all blood. Immediately after flushing the port, close off the tube as to prevent any blood backflow that could clot up your catheter. Repeat this process with the other 2 ports to ensure that you have 3 ports that all return blood and all flush easily. There are some numbers to memorize as far as how deep the central line should be placed in certain sites. As far as IJs go, it should be placed about 15 to 16 centimeters at the skin. Subclavian should be placed about 17 or 18 centimeters at the skin. This will get the tip of the catheter and the SVC, which is where you want it. Femoral lines, I always just insert to the hub. You can't really get too deep in a femoral line.